Yeah.
Yes? Is it better with the... Is it better with this? Okay.
Thank you very much for the invitation to our co-chairs, Mina and Sue, to my good colleague Nadia for introducing me to the group, and for you all being here this afternoon. I am going to introduce you to the Women's Health Network, which is very, very new. I've only been in this role for 2 months. And so a little bit about my presentation is going to be outlining what the networks are and how they fit into our health service at the moment in Wales, which I think is really important for those who are healthcare professionals, third sector, and of course we ourselves as the public who use our health services. So as I said, I have only been in the role for 2 months, and very early on in my new appointment, I approached a colleague and very proudly said, I am going to be the clinical lead for the Women's Health Network. At which they immediately responded and said, well, is there going to be a men's network? And I was a little bit taken aback, and I probably got a little bit defensive in my response, but I've had time to think. And wouldn't it be great if we didn't have to have a women's health network? If the difference between men and women and their biological makeup had been considered from the offset, thank you, Adam and Eve, if there was no gender, race or cultural biases which impact on the way that we access healthcare and lead to a full and healthy life. But we have got to where we are because there are those gender biases, and it's because the default to date has been men. And as a result, women's needs, women's health has been lost. And so yes, to my colleague, we do need a women's health network. I'm going to outline a little bit today, as I said, about the NHS executive, the political landscape of women's health, touching upon some inequalities, specific inequalities in women's healthcare, and then our next steps. So for you who don't know, the NHS Wales executive is quite new as well, approximately 2 years old, and it was built and born out of a Healthier Wales that really looked for a commitment to developing a national clinical plan for services in Wales, that guiding hand to be able to deliver equitable, safe services. And the framework speaks of a health system that is coordinated nationally but delivered locally. And for those of you who perhaps like pictures, this might help to explain it a little bit better. The NHS executive sits in the middle between Welsh Government and also NHS Wales. And it's that collaboration that the networks are going to bring between the policy setting of our colleagues in Welsh Government and the delivery on the ground. There are 11 networks, for those of you who may not be aware, and there are 2 programmes. They are more disease specific, so cardiovascular disease has a network, respiratory has a network, musculoskeletal has a network, and then there are some that are more service-based around maternal and neonatal services, for example, and then there are 2 that are population-based, and that's women's health and child's health. And a significant amount of investment has gone into setting up the networks and developing the networks and the infrastructure to support them. And that's a key USP, I think, of the networks in the fact that they are clinically led. Myself, I'm seconded to the NHS Executive for 2 years out of my current role within Howell Var, and it takes up a significant proportion, 4 days of my current role. And our work will be to collaborate with colleagues on the ground, but also listening to the voices of those with lived and learnt experiences, and ensuring that the quality statements are being used when setting the targets for developing services. So the discourse around women's health has really grown and gathered speed in the last few years, which for me as a women's health specialist is incredibly exciting. My own interest in women's health was first sparked in 2004, training as a GP in Scotland, where there was a bit of an expectation as a female GP that I would get all the women's problems, so I'd better do the diploma in family planning. This developed further when on my return from a year-long working as a volunteer in South West Africa and a Masters in Public Health, I took on what I thought was a standalone job in East London, working in their contraception and sexual health clinic. But it was here that I found my passion. Sexual and reproductive health care brought together my interest in population health, prevention, but also that holistic approach to health, because sexual health, contraception, having a family is not one thing, it's not one biological thing. It's about heart, it's about the body, it's about the soul. And that's what interested me and excited me about SRH. Then in 2015, I read Dame Sally Davis's annual report, the then CMO in England, called Health of the 51% Women, where she challenged the stigma and embarrassment that women feel and experience when talking around their problems below the waist. Problems below the waist, she said, are not generally seen as attractive topics for public discussion, and women are often reluctant to seek help for common disabling conditions. This needs to end. Women should never suffer in silence. Breaking the taboo around these subjects will help more women come forward and get the care they need. And although I am proud to stand here as the first clinical lead of the Women's Health Network here in Wales, I'm a little saddened that we are still talking about the same barriers, challenges, taboos and stigma that women experience and impact on their day-to-day health and well-being, and that progress often is just too slow. So what has been happening in terms of Wales and women's health and the political landscape? In 2022, we saw the publication of two documents from Welsh Government, the Quality Statement for Women and Girls and the Discovery Report. The introduction of a quality statement was signalled in A Healthier Wales and set out the expectations for the future planning and accountability arrangements for the NHS. The 6 quality attributes which the statements highlight are that services need to be equitable, safe, effective, efficient, patient-centred and timely. And within the quality statement for women and girls, there are 23 quality statements for the health boards to benchmark against. And of course, the Women's Health Network, with the help of the NHS Executive, will help to direct, support and enable health boards to deliver improved services for women and girls against these quality statements. The Discovery Report was commissioned to hear the voices of women and girls around Wales on their experiences of accessing and using women's health. The survey attracted over 4,000 individual responses for women and girls aged 16 to 85 and provided incredibly rich detail on the issues and concerns affecting them. In addition, over 1,000 people from across Wales registered their interest to take part in focus groups to inform the work. 6 key themes emerged from the responses. Women reported that taboos and stigma remain when discussing their health and well-being, which can be a barrier to receiving the right help. They reported that medical professionals often don't listen to their concerns or take them seriously, a problem that is even greater for women from marginalised and underserved groups. Secondly, women reported serious challenges in accessing healthcare. They can't get through on the phone, can't get appointments unless urgent, and once in an appointment, there isn't enough time. As a result, women are more likely to wait until symptoms are bad, which has a knock-on effect to create more pressure for the NHS in the longer term. The third theme looked at health and well-being. Women reported multiple impacts to their well-being, ranging from feeling overwhelmed and stressed to worrying about financial and caring responsibilities. The respondents highlighted that women generally bear the larger share of additional responsibilities above and beyond their working life, with reference to expenses and affordability, particularly around childcare, adult care, and those with disabilities. Within the workplace, women experience significant discomfort discussing health issues in the workplace. Women identified they often had specific needs which were not accommodated. For example, 25% of women don't want to talk about their periods at work, yet 89% have experienced anxiety and stress in the workplace due to their periods. And finally, research. Overwhelmingly, the feedback asked for more research into women's health. As one respondent said, we need increased training and research surrounding all elements of women's health to ensure the medical gender bias, gap and bias towards the male norm, is urgently addressed. Across the borders, things are a little bit further ahead. The Women's Health Strategy for England was obviously published in 2021, and the policy for Scotland, the Scottish Health Plan, was published in 21, and I was speaking to them last week. They're about to do their second iteration of their plan. But we're in good communication with them, and I think there's an opportunity that we can have lessons learnt, and we can build on what they've done, and that we can be able to take some of that into our own policies here in Wales. And it would be amiss of me not to mention an excellent document that was also published in 22 by the Women's Health Coalition. Many of our colleagues here from different charities may already be a part of the coalition, which is made up of 60 different charities. And they produced the quality statement in 22, which outlines or details some of those fundamental gaps in care around women's health and the aspirations for the future. It is so important for us to start reflecting on women's needs across a wide range of conditions, not just gynecological conditions. Women's symptoms and clinical presentations of many non-gynecological conditions are different to men. It can be asthma or mental health. We need to start collecting that all-important data that was mentioned by our colleague earlier on, highlighting where there are differences between men and women. There are over 1.6 million women and girls living in Wales, making up 50.7% of the Welsh population. Over time, life expectancy has increased in both men and women. Women in Wales live on average 82.1 years, whereas men live 78.3 years. Although women live in longer, we now understand that women live more of their later years in poor health. Termed healthy life expectancy, women in Wales can expect to live a healthy life until, on average, 62.4 years, with the following years, 20 years, spent in ill health. And this inequality is further increased when we consider deprivation. Deprivation, by definition, is the damaging lack of material benefits considered to be basic necessities in society, things that you and I take for granted. So the gap in healthy life expectancy between the most and the least deprived in Wales is almost 17 years. So women in the most deprived parts of our country are by definition experiencing the damaging lack of material benefits that you and I consider taken for granted, and they also have the poorest health for a significant proportion of their shortened life. Respondents to the survey, the Discovery Report, also talked about not being listened or heard. They had to fight to be taken seriously, and that there was often an unconscious bias from healthcare professionals against women exacerbated by age and race. For example, some felt that they were not old enough to have real problems. For older women, they said that they were often made to feel that because they were old, they shouldn't expect good health, and so some degree of suffering was normal. I'm one of 4 girls, all of us born in the 70s, and I remember asking my mum about her experience of childbirth. She tells often a very stoical, but what I think is quite traumatic story of my birth in the late 70s, I just like to say. And at the end, I always say to her, "Mum, that sounds horrific." And her response to me at that point, and I was probably around 20 years old, she said, "Dear, you leave your dignity at the door when you have a baby." And that's always stuck with me. And I think I took it for granted and accepted when I was a young person. And now I'm starting to question that's not right. You shouldn't have to leave your dignity at the door when you go in for a gynecological procedure, a smear test, having a baby, anything at all. That shouldn't be accepted, and that should not be the societal norm. I want to take a moment just to touch upon some areas Where we have got some disaggregated data, where we have started seeing the difference between the way that men and women respond differently to healthcare. Mental health is one of those areas where we see the difference. Older women are more vulnerable to mental health problems, with depression affecting 28% of the female population of the UK aged over 65. Rates of mental health are rising much more quickly among women than men, and women report facing specific barriers to accessing their help related to gender. From the Discovery report, again, we picked up on themes around stigma and embarrassment when talking around mental health. And in the Women's Mental Health Task Force report published in 2018, respondents went further and said their concerns around fear of disclosure were that their children might be taken off them, as well as the stigma or judgment that women felt that they would be seen as an unfit parent. And I just wanted to highlight another concern that was picked up, and I've talked to my colleagues in Bowzo and Iris Eye outside, is that there is an increase around suicide in the perimenopause and immediate postmenopausal age. And the work of Iris Eye and Ava is so important because what they're doing is working amongst particularly primary healthcare practitioners to raise awareness around domestic violence and this risky time in the perimenopausal period when there becomes more at risk of domestic violence and suicide. And so their campaign Stuck in the Middle with You is so important, and please do speak to our colleagues outside on the desk about that. Cardiovascular disease. This is another area where we have finally some disaggregated data around men and women. A report by our colleagues in the British Heart Foundation called Bias and Biology is an incredibly helpful piece of document which I would encourage you to have a look at. At every stage, diagnosis, treatment and aftercare, women who have heart attacks receive poorer care than men. Women are 50% more likely to receive a wrong initial diagnosis when they have a heart attack. Women have the same symptoms as men, central crushing chest pain and shortness of breath, but they're less likely to receive a diagnosis of a heart attack, 34% less likely to receive their coronary angiogram within 72 hours of symptoms than men, and that's a gender bias. More than 8,200 women in England and Wales needlessly died over a 10-year period because they did not receive equal treatment to men. And women were less likely to receive statins and beta blockers, important medications, which on release from hospital could help save your life, compared to men. So we have a lot of work to do, and what I will be working alongside the Cardiovascular Disease Network is raising awareness around this and thinking about how we ensure we can get this trickle down to the ground and raising awareness at every level. Dementia. Women are more likely than men to develop dementia. Of all people with dementia in the UK, 2 in 3, 65% are women. Dementia has remained the leading cause of death for women since 2011. Reasons for this are still not fully understood, but it could be around hormone changes or high blood pressure and different rates of physical activity. But what this also highlights is that women have been excluded from clinical trials often. They have multiple morbidities, which means that they're less likely to be included in those trials, which looks at specific medications that could obviously save their lives. I want to highlight this quote from Caroline Criado Perez. I don't know if anybody are aware of her book, which is about invisible women. And I do recommend it if you're more interested in looking at data and that lack of data around women. Data shows that healthcare is systematically discriminating against women, leaving them chronically misunderstood and misdiagnosed. It's so important that we do disaggregate that data in everything that we do. We don't know what we don't know. We need to work across specialties and link data, improve how it is reported and reduce that variability so that we're not trying to compare apples and pears. We're going to work with primary care and particularly around the community pathways so that it's done in primary care as well as secondary care. And I would ask anyone who's listening today who collects data, looks at data, stores data, analyses data, we need to disaggregate in the first instance by male and female so that we can find out more information. And in the long term, this will benefit men as well. And finally, what is next? Dame Leslie Regan, who's the women's health champion in England, wrote this: "Healthcare is about giving the tools so that women and girls can make choices, preferably healthy ones, to support them to remain well throughout their lives and to not just intervene when they are unwell." What an opportunity we have in Wales to set an ambitious agenda in our Women's Health Plan for the next 10 years, a plan that is co-produced and co-designed by the Women of Wales. My role as the clinical lead for the network will be to help shape that blueprint, to link and collaborate with the amazing academics that we have here in Wales, working on research that will provide the evidence to show us how we need to do things differently. I want to work with the clinicians and third sector, people with lived and learnt experience. We need to work with our digital teams to find out how we can capture data better across the country, where there are gaps, but also to celebrate the successes and then take those with learning across the country. And I want to hear from you. So I'm really pleased to be here this afternoon. And if you do have any further questions afterwards, I will be here the rest of the afternoon. I would want to hear from you, particularly from organisations who want to be part of the reference group which will feed into the Women's Health Plan. So please get in touch.
Thank you very much, Helen.